So good afternoon, everyone. Thank you for this opportunity to share our results with you today. So to reach the UNAIDS 1990 targets, we need strategies both for high uptake of testing and high uptake of linkage to care. Community-based HIV testing, including campaign, home, mobile, self, and outreach testing to key populations, can achieve 90% testing among HIV-positive persons. Following testing, linkage strategies, including counseling, referral, point-of-care CD4 testing, text messages, clinic facilitation, and lay counselor home visits, all increase the uptake of clinic visits, ART, and viral suppression. However, the optimal linkage package of streamlined, scalable strategies needs to be defined. So to define this optimal package for linkage, we conducted an individually randomized trial to test approaches to linkage to HIV care and prevention on a backbone of community-based HIV testing and counseling. We conducted home and mobile testing as the platform for linkage to care and prevention. HIV-positive persons were randomized to linkage to HIV care strategies, and HIV-negative uncircumcised men were randomized to male circumcision demand creation strategies. For HIV-positive persons following testing and counseling, they were randomized to either receiving point-of-care CD4 testing at the time of HIV testing or being referred to the clinic for CD4 testing. Then in a factorial design, they were further randomized to either clinic visit facilitation, and in this arm, a lay counselor met the participant at the clinic for the first visit, or they were randomized to lay counselor follow-up visits at home, and in this arm, the lay counselor visited the participant at home at months 1, 3, and 6 and provided counseling support for HIV care, ART initiation, and adherence. Or they were randomized to the referral for HIV care arm, which is the standard of care arm, and they received referral to the clinic. The outcomes for HIV-positive persons were obtaining an initial CD4 count result, clinic linkage, which was visiting an HIV clinic and registering at the clinic, initiating ART, and finally viral suppression. For HIV-negative men, following testing and counseling, they were randomized to receiving a text message, and this was a motivating, unidentifiable message that was sent at months 1, 2, and 3, or randomized to lay counselor follow-up at home, where they received lay counselor home visits at months 1, 2, or 3 until they were linked, or to the standard of care, the referral arm, which was promotion of male circumcision at the time of testing. And the outcomes for these arms were visits to male circumcision clinic and uptake of male circumcision. The study was conducted between June 2013 and February 2015 in KwaZulu-Natal, South Africa, and in the Shima district in southwest Uganda. 1,325 HIV-positive persons were randomized to HIV care and ART linkage strategies, and 750 HIV-negative uncircumcised men were randomized to male circumcision linkage strategies. We had 96% study retention. Overall, the HIV-positive persons were young, with a median age of 31. Just about 30% were men, and 75% were previously unaware of their HIV-positive status. The median CD4 count was fairly high at 512. And these are the results for the point-of-care CD4 testing. 100% of participants in the point-of-care arm received their CD4 count results, and 80% of participants in the clinic referral arm received an initial staging CD4 count, with a relative risk of 1.25, a 25% increase in obtaining a CD4 count result. But despite this difference, there was no difference in uptake of clinic visits, ART initiation, or viral suppression. Looking at the results for clinic visit facilitation compared to the standard referral, overall linkage to the clinic was very high, 98% in the clinic visit facilitation arm and 89% in the standard of care referral arm. So the relative risk of 1.09, a small but significant finding. And for ART initiation, among patients in the clinic visit facilitation arm, 37% initiated ART compared to 34% in the referral for HIV care arm, with a non-significant relative risk. And for this comparison, there was no difference in viral suppression. When we looked at the comparison between lay counselor follow-up and the standard referral arm, for linkage to an HIV clinic, again, we saw in both arms high linkage to clinic, 93% in the lay counselor at home follow-up arm and 89% in the standard of care arm, with a relative risk of 1.04, again, a small but significant increase in linkage to clinic. And for ART initiation, 41% of participants in the lay counselor follow-up arm initiated ART compared to 34% in the referral for HIV care arm, a relative risk of 1.23, which was statistically significant. And there was no difference in viral suppression between these two arms. Overall, the reasons for not initiating ART reflected bottlenecks in care at the clinic. 44% of participants were told they were not eligible for care, and then many participants reported logistic barriers, multiple visits for pre-ART care, and waiting times for repeat CD4 counts and for linkage to care. So moving now to the results for the linkage to male circumcision arms. Overall, the participants in these three arms were young and with a median age of 23, and 60% were tested for the first time. And this Kaplan-Meier plot shows the uptake of male circumcision at month 3. So in month 3 at the standard of care promotion arm, 28% of men reported they were circumcised compared to 48% in the text message arm and 47% in the lay counselor arm. And this was, in both comparisons, a significant relative risk of 1.72 and 1.67, so a 72% increase in the uptake of male circumcision with SMS messages and a 67% increase in the uptake of male circumcision with lay counselor follow-up visits at home. So we found that clinic facilitation and lay counselor home visits modestly increased linkages to HIV clinics, and lay counselor follow-up visits at home increased ART initiation by 23%. Among people who were eligible to initiate ART, only 67% initiated ART by month 9 due to logistic barriers at the clinic. And additional strategies are needed to address clinic delays and barriers to ART delivery. Uptake of male circumcision visits to male circumcision clinics overall was high, 70%, and the strategy of text message reminders and lay counselor visits significantly increased the uptake of male circumcision by 72% and 67% at 3 months, and this impact was sustained at 9 months. Text messages and lay counselor follow-up visits increased the demand for male circumcision and could be integrated into existing services for HIV testing and male circumcision. So in summary, we found that community-based, lay counselor-led linkage strategies can increase linkage to care and ART for HIV-positive persons, but for HIV care, we need additional strategies to simplify the in-clinic ART initiation procedures. Text messages and lay counselor follow-up visits are scalable strategies that have the potential to have a large impact on the uptake of male circumcision. I'd like to conclude by thanking our study participants our outstanding collaborators at ICOBE and the HSRC, and the outstanding Linkages study team and the principal investigator of the study, Connie Kellum. Thank you.